So welcome, everyone. Thank you so much for joining us. Welcome to Compassion and Choices webinar, New Jersey's Medical Aid in Dying for the Terminally Ill Law. This webinar will address how to prescribe under New Jersey's new Medical Aid in Dying law. Thank you so much for joining us. Throughout this presentation, we'll be taking questions from the audience by having you type your question into the Q&A box on the screen and then clicking send. We'll answer as many questions as we can at the end of the presentation. But before we get started today, please note that today's webinar will be recorded. Although everyone who's participating tonight is in view only mode. So that means that you'll be able to see the webinar, but we can't see you. So the recording is in progress, but your audio and video functions are disabled and neither will appear in our recording. So tonight we're going to be hearing from Dr. David Grube, who is Compassion and Choices National Medical Director, and Dr. Deborah Pasik, who is a practicing physician in New Jersey. And I will introduce you to them in a moment when we turn this over. Compassion and Choices is the nation's oldest, largest, and most active nonprofit organization working to improve care, expand options, and empower everyone to chart their own end-of-life journey. We believe in patient-centered care, where the person is in charge of making their own healthcare decisions. Also, that people should be fully informed and supported by their doctors and medical team on the full range of end-of-life options. I just want to give a quick history on New Jersey's Medical Aid in Dying for the Terminally Ill law. We have come a long way in New Jersey. The bill was first introduced in 2012. It was passed by both houses of the legislature in 2017 when then Governor Chris Christie threatened to veto the bill. In January 2018, Governor Phil Murphy was sworn in, and 2 short months later, the Assembly Judiciary Committee approved the bill. Fast forward 6 months or so, and the Senate Health Committee approved the bill. In February of 2019, the bill was passed by both houses of the legislature the month after, and Governor Murphy immediately vowed to sign the bill and did so in April of 2019. The law took effect on August 1st, and then a restraining order put the law to a halt for about 12 days before being overturned. That legal challenge continued while the law was in effect and was ultimately dismissed on April 1st of this year. The State Department of Health released a 6-month report on the implementation of the law, and so now we've got a fully functioning law, and Compassion and Choices is committed to making sure that doctors and healthcare providers across the state are equipped with the tools that they need to be able to practice under this law. You can see that, medical aid in dying laws are being authorized at a rapid pace. The first law was passed in 1994 through voter referendum in Oregon. And then, there was a period of time where there was no development in this field. There was a lot of development in the hospice and palliative care field, but it wasn't until 2008, 2009, when Washington and Montana authorized medical aid in dying through a court decision, Washington through a referendum, and then Vermont in 2013 through the legislature, and then for the past 5 years, we've seen 6 states authorize medical aid in dying. Most recently, Colorado, Washington, D.C., Hawaii, New Jersey, and Maine. Both New Jersey and Maine passed their laws both in 2019. Before I get going here, just so you know, our campaign at Compassion and Choices was focused on passing the law, but since then we have engaged in a vast amount of public education. We've conducted outreach to providers and health systems. We've sought to expand access to care. We've forged new partnerships with professional associations in the state. We have mobilized in defense of the law, and we have shifted our work since March to focus on providing tools for people so that they're equipped to do advanced care planning in light of the COVID-19 pandemic. So we've been very busy at work providing the tools to people in the Garden State to chart their own end-of-life journey. That's all you're going to hear from me for now. I'm going to turn it over to the capable hands of both of our medical professionals, Dr. David Grube and Dr. Deborah Pasik. And I'm going to ask them to address for a few moments, why do we need this medical aid in dying law? And Dr. Pasik, I think you're going to go first. Is that right?
Am I telling a story? Or...
Yeah.
Okay.
Yeah.
Okay, yes. Hi, everybody. Welcome, and thank you for having me. I was asked to speak about a personal story regarding medical aid in dying. And it didn't take me long to decide that I really couldn't think of any story more appropriate and meaningful to me as that of my first patient. Her story is just so representative of everything patients that are seeking medical aid in dying have to go through to achieve their planned dignified death. The first encounter with this patient was early in August, right after the law was enacted, and it was through a letter written by her husband, in which he stated that he was sending this letter to 20 physicians that he found in a New Jersey publication. This was after having called over 60 physicians to see if he could find someone to prescribe for his wife. He stated that he and his wife had been waiting anxiously for the law to become available, as she had been suffering from terminal colon cancer for over a year, and in fact had outlived her prognosis already. The letter was an incredibly impassioned plea for help, as every physician that they had contacted so far would not agree to see her. This seemed really disturbing to me, as I would have expected that in a group of 60 physicians, 60% of them, as per national and statewide surveys, would be in support of the law. But this general support didn't translate into prescribing, as none of these physicians apparently were comfortable prescribing for someone who was not already a patient in their practice. So I agreed to see her. Her story was typical. She had metastatic cancer, she was in significant pain, and she was unable to tolerate any type of analgesia because of severe nausea and vomiting. At her first visit, it was really clear that she was terminal and suffering terribly. It was so bad, she was so bad clinically that I even questioned myself if she would even make it to her next visit. But she did, and I ultimately wrote prescriptions for her. What was remarkable about her at the time, though, and has been a consistent finding that I have seen over and over again since then, was that her first visit, she was quite apprehensive and defensive about her wishes, which was understandable, as she had been unable to get anybody to listen to her before. So we talked for a really long time, about 90 minutes, mostly about her life, of course, after dispensing with the obligatory dialogue for information and documentation. In contrast, her second visit showed a completely different person. Although clinically, when she walked in, I was really horrified because she had lost a great deal of weight, more weight than before, and was now prominently jaundiced. But she had a smile on her face. Her mannerisms were easy and conversational, and we went through the process again, and I told her that her prescription was going to be waiting for her at the pharmacy. At which point, she stood up with great difficulty, opened up her arms, and said, "I would hug you, but I think it would be too painful for me to do so." She was grinning from ear to ear, and she had tears in her eyes, and I had a really hard time keeping my tears in check at that point. Then she walked away, holding on to her husband. Her shoulders were square, her head was held high, and the next day she died her planned death. This first patient affected me really deeply and charted the course for me to go forward. As an advocate during the legislation of this law, I felt very strongly about it, but didn't think I would ever become a prescriber, as my patient population was not one that was prone to terminal illness. I also very naively assumed that the patient and all patients would be able to get care from their own physicians. But as this was not the case, and still is not the case for the most part, I felt an obligation to jump in and be a part of this. The big moment of truth, however, came when I was actually writing the prescriptions. As I was handwriting them, my hands were shaking, and I had this freak out moment when I realized I was writing lethal doses of medications that would end a person's life. I think I checked them over at least a dozen times and finally put them away. I wasn't really uncomfortable with my decision, but I was actually more scared than anything else. But after her second visit, when I saw what the availability of medical aid in dying had done to her morale, I knew it was the correct thing to do, and I would continue to do so moving forward. I really hope that after hearing this story, I can encourage all of you who are in support of medical aid in dying, but are not comfortable prescribing for a variety of your own personal reasons, to just go with your gut and push past that initial hesitancy and doubt about your ability to do so, and see what kind of emotional rewards you can reap from helping someone achieve a planned and dignified death. Thank you.
Oh, Dr. Pasik, thank you so much for sharing that story. It's very touching, very moving. Dr. Grube, I'm sure you have a library of stories you could share with us.
Thank you, Corinne, and thank you, Deb, for that as Corinne said, very touching story, and so typical of experiences that I've also had from patients and still have from their families for individuals that I responded to their requests. I'm here in Oregon, so a long ways from the Garden State, but the story that I want to share is a little different kind of story, because one of the things that we still hear almost on a daily basis is that a medical aid in dying law is not necessary if we can provide hospice and palliative care. And the story that I want to share with you is an example of why that is not true. This was a neighbor of mine who had bladder cancer. It was spread through his body, especially into his bones. And he was not able to have his pain managed in spite of the fact that he was in hospice and had an excellent hospice team and was at home. But he was suffering incredibly. He wasn't my patient at that time. I mean, he had been, but after he'd gotten his cancer, he'd sort of gone into the hospice and oncology arena. But his son called me one day and asked me, I happened to be home on a day off, to come over because there was something, in quote, wrong with my dad, end quote. So I drove over to the house. The son was sitting out in the front room, and the TV on in the bedroom was very loud. I went in to see the fellow, and he was sitting in a chair, and he had a shotgun between his legs, and he had taken his life. This is the worst day. I practiced medicine, family medicine for 40 years. This is the worst day of my clinical experience. I still think about this too often. It was a terrible, terrible mess. And we had to prevent his wife from coming home. And then after his body was taken, we had to, my wife and I and another neighbor came and spent hours cleaning up. And I said to myself, you know, this can't be the end, the last chapter for anybody's story. This just can't be. This gentleman had excellent medical care. He had a terrible medical problem, and it was before the Oregon law was passed. So that affected me a lot. And when our Oregon law was passed and the first patient requested aid in dying from me, I spent a long time talking with the person about why they would even want to think about doing this. But I had no hesitancy when it came ultimately to the moment of writing the prescription, because I remembered my neighbor.
Oh, Dr. Grube, thank you so much for sharing that story. I wish I could say that that's the first time I heard a story like that. But sadly, it's not. So many of the physicians that supported the passage of this law shared similar stories like that. Thank you for sharing that this evening. Well, let's dive right into this presentation. I just want to remind folks that if you have questions, we will answer them at the end. We'll answer as many as we can. And so just look at the bottom of your screen to the Q&A box, type in your question, hit submit, and we will get to as many questions as we can at the end. And I'm going to turn it over again to Dr. Grube to talk about the national overview of this issue and guidance for physicians and the resources that we have available to you. Dr. Grube.
Thank you. Thank you so much. Well, we'll spend a few minutes talking about this. Corinna is going to be running the slides, so we can go to the next slide, please. As you learned, a number of states have passed aid in dying, and now over 1 in 5 Americans have this as an option. So while you live in a state that is authorized now, there are a couple states right on your borders, Pennsylvania, New York, that are considering passing this law, and there are a lot of other states that are considering passing this law. And so it's my thought that as dying becomes ever more complicated and dying patients have suffering situations, as we've told in our stories, that this will be an option for terminal patients in quite a number of states in the near future. Next slide, please. There's strong provider support for aid in dying. As you can see, these are just a list of the number of different organizations. I might say that in spite of these organizations passing laws that are neutral or support, or I should say are not opposed anymore, it still happens. Just a couple weeks ago, the Maryland Medical Association had a resolution to return to a position of opposition, and it failed about 75 to 25. And also last month, the American Academy of Family Physicians, my group, had again at our Congress of Delegates a Kansas resolution opposing aid in dying that did not pass, and so the Academy is still neutral in regard to aid in dying. Next slide, please. These are a number of organizations that have neutrality, particularly the American Academy of Family Physicians, the American Academy of Hospice and Palliative Medicine, the American Nurses Association, American Academy of Neurology, and so on. Next slide. When a patient asks you about medical aid in dying, we need to be prepared. No matter what our feelings are, whether we're going to be respond to their wishes or we need to be prepared. So that's why we're here tonight, to get education, to explore our own personal beliefs and where we stand in regard to this, and to have to develop a consultation with our peers about what how we will respond to a request. The main thing I want to recommend is that you listen to your patients. Why are they asking this question of you? Why are they saying to you, I want to consider this, doctor? Because too often I hear stories from patients and others that a doctor's response will be, oh, I just don't do that, or that's not something I believe in. I think that's unprofessional. I think it's almost a form of abandonment. If they're asking about aid in dying, they have in their belief or in their life, they are suffering in some way. So you need to explore that with them and find out what is it that hospice is not doing or palliative care programs could do better. Why are they asking this, and get it and put it in context and explore their fears and wishes and values, just as we do when we have a conversation about their advanced care plan. So listen to the patient and engage the patient, and don't please tell the patient that's not something that you do. If it is not something that you believe in, then I think it's important for us to refer the patient to someone who will talk to them about all of their end-of-life choices, not aid in dying, but all end-of-life choices. Just as when we refer somebody with abdominal pain that we think is appendectomy, we don't refer them for an appendectomy. We refer them for evaluation of options for approach to abdominal pain. Next slide, please. Now, there are some components in the New Jersey law that are based on the Oregon law, as all states are. There's essentially these groups that, and I think Dr. Pasik is going to talk to you more about this specifically, but there's the attending physician, who is the individual in charge of the patient's care. There's the consulting physician. So 2 physicians always, it's necessary to review the eligibility requirements. If there's a concern that there is active mental illness that impacts decision-making or capacity, then a mental health consultation would be necessary. This is quite uncommon. Yes, these patients are grieving. They all have a grief reaction. They're about to die and they want to live. But that does not necessarily impact their ability to understand informed consent, and it may not impact mental capacity. Other team members have important roles in aid in dying: pharmacists, social workers, a chaplain, and the nurse, and we'll talk about that in a minute. Next slide, please. So the attending physician determines the eligibility requirements and puts them in the record, refers the patient to a second physician, and as I mentioned, to a mental health professional if there is evidence of incapacity. And it's important to counsel the person of the safekeeping of the medication, of the notifying of next of kin, of having a person present when the medication is taken, and of all other end-of-life options, including hospice and palliative care. Next slide. The consulting physician also examines the patient, and by the way, these can be done through telemedicine, either of these with the attending or the consulting physician, if it's appropriate. So that is legal in New Jersey. There's a form to complete and to confirm to the attending physician of the eligibility that the patient has made. And also this consulting physician could refer the patient to a mental health professional if that is appropriate. Next slide, please. The pharmacist has a big role in medical aid in dying. The medications that are used now are compounded, and so the physician should contact, and I would say personally talk with the pharmacist to make sure that they understand. And sometimes the pharmacist will want to interview the patient herself or himself. They have to compound the medications to dispense them, and in most states there's a simple form the pharmacist might complete. Next slide, please. It's very interesting to me that I always offered to attend a planned death if that's what the patient wished. Interestingly enough, it was uncommon that the family wanted me to be there, but who they want to be there is their hospice nurse. All of these patients are in hospice, and so that's interesting, and so we want to make sure that the hospices are also prepared to respond to this request. Next slide. The social worker has a very valuable role in this. These patients are sick, their families are confused and under a lot of stress. And there are these steps that I've been outlining for you. So the social worker oftentimes has the role of a navigator. That is someone who assists the patient to go through the steps and the processes, contacting, driving to appointments, etc., all kinds of things that can be done. And in our hospice here locally where I live, the social worker takes the role of navigator in these cases. Next slide. So there are these requirements and these steps which are protections, but also end up being barriers. You have to ask the attending physician on 2 separate occasions separated by 15 days. There's also the request that has to be done to the consultant physician. And then furthermore, there has to be a written request that's signed by 2 witnesses, and one of whom cannot be related to the patient, and neither of them can be a member of the healthcare team taking care of the patient. Next slide, please. As I mentioned, the CARES Act allows telemedicine to be used. Most of these patients we know pretty well. We've been taking care of them for years. But if they are newer to our practice, telemedicine may or may not be appropriate. But these are very sick people. And not only is it dangerous perhaps for them to come into a facility and contract the virus, but it's very hard for them, even before the pandemic, for them to make visits. I was lucky. I live in a small town and I was able to do house calls easily, but that's not always possible in a more urban area. Next slide. I want to make this really clear because this myth is still out there. Doctors say that, well, I may not want to do this because I don't want to get sued. It doesn't happen. It's never happened in any state where aid in dying is authorized. If we follow the steps that are outlined in your law, there is no risk for a malpractice case or disciplinary action from a licensing board. On the other hand, there is also no duty to participate, and so any nurse or physician can opt out and does not have to participate in the process. Next slide, please. If the individual takes aid in dying medications, it does not impact any contracts. And by law in New Jersey, by law, this is written in your act, medical aid in dying does not constitute euthanasia, mercy killing, homicide, or suicide. It is not those things. Next slide. I want to quickly show you this slide to outline two things. This is data from Oregon since the beginning. Our law first passed in '94, but did not take effect until '97. And so we have this data. The two things to notice from this are that fully a third of people who get a prescription don't take it. 2/3 of people end up taking the medication, and 1/3, as Dr. Pasik so clearly outlined, are so empowered and so happy to have the medicine that they may not ultimately choose to use it. And the second thing is that this in New Jersey, as in all other states, this will be something that's talked about a lot. People want to know about it and learn about it and consider it, but it's rarely used. In Oregon, last year, we had 170 some odd deaths from aid in dying medication out of 36,000 plus deaths. So less than 0.05%, very uncommon. Next slide. Why do people want aid in dying medication? Well, as we heard so clearly in Dr. Pasik's story, they want to be empowered to have some control. They are about to die. They don't want to die, but they're suffering in some way. The suffering could be pain, as in that story, or the suffering could be some other existential type of suffering, such as no pleasure in life or inability to, I had a patient who had such bad odors from her discharges that she didn't want her family to be around. Loss of dignity, incontinence, loss of control of bowel or bladder, etc. The suffering is from the patient. We need to remember it's not our determination if we think they're suffering. If they're telling us they're suffering, we need to explore what that means. Next slide. I'll briefly speak to you about the medication. The medication is self-administered. That means the patient takes it. We can assist the patient. That is, we could prepare the medication, bring it to them, hand it to them, whatever, but they must self-ingest the medication. They usually fall asleep within 10 to 20 minutes, and their time to their death is generally an hour or maybe a little bit longer. It's a gentle death, a sleeping and a peaceful death, it's almost as those of us who have attended a planned death, generally it's with the family in the room and their music and their candles, and it's almost a sacred type of death. Next slide. Pre-meds are given an hour ahead of time on ondansetron and metoclopramide. 30 minutes later, 100 milligrams of digoxin, and 30 minutes after that, this combination of diazepam, morphine sulfate, amitriptyline is given in about 4 ounces of juice or water. So it's about a half a glass, needs to be swallowed fairly quickly in less than 90 seconds, because if they sip it, they'll fall asleep before they get it in. The last 4 medications can be taken together 1 hour after the pre-medications, but the reasons that are usually separated out, of course, as you can see, is because the aliquot of digoxin is so much smaller than the doses of the other 3. Next slide, please. Sometimes there's a little burning from the amitriptyline. So it's a good idea to have some sorbet on hand. Sorbet is a frozen fruit juice, and the flavor that they like, and it's cold and it soothes the esophagus and mouth. So a few tablespoons of sorbet, it's a good idea. Not all patients, 90% of patients don't need this, but the last moments of consciousness should be pleasant moments. Next slide. There are a few red flags about the medications, GI malignancies in particularly, or GI issues with absorption. So if the patient has some of these things, might want to consider take a step back and think about it a little bit more. Also, morbidly obese patients, which are quite rare in dying patients, but patients with bad alcoholism, such as drinking more than a fifth of alcohol a day, or people have high doses of opioids, they might want to think about this. What really it means is that their time to death might be a little bit longer. The family should be alerted to that. Next slide, please. Federal insurances do not pay for this. Medicare and the VA do not pay for this. But in Oregon and this is a slide from California, I'm sorry, but most private insurances and Medicaid pays for it. I don't think New Jersey has determined yet if your Medicaid program will pay for it, but maybe Dr. Pasik could answer that in a minute. Next
That's right, Dr. Grube. That's right. It's an unanswered question at this point.
Yeah, that's what I thought. Oregon, Washington, California, Hawaii does pay for it. Next slide. On the death certificate, we write the cause of as the cause of death, the terminal disease, lung cancer, ALS, or whatever. Just as in an example, when someone is on renal dialysis and stops renal dialysis and dies of renal failure, we don't write the cause of death as being stopping dialysis, it's kidney failure. So similarly, the cause of death is the terminal disease, and that's what's written on the death certificate. Next slide. So, summing up, really, aid in dying in the states that have had it for quite some time shows that it works. It's palliative, just having the prescription. It's palliative, as you saw in the case of Dr. Pasik mentioned. There's a number of reasons why people consider this, which need to be explored in every case. And groups such as the disabled, the poor, minorities, elderly, none of them have ever been, it's never been demonstrated that there's been any abuse of these laws in those groups, as this is a volitional act by a dying person and not by someone else, not a caretaker or something. Next slide. So finally, as Dr. Pasteur said, one does not ask of our patients, what is your country, what's your religion, etc. We say, if you're suffering, that's all I need to know. I'm going to take care of you and help you. Next slide. Next slide is just sort of resources that we have for you from Compassionate Choices. And I think those will be outlined later too, so, but it'll be in the slide deck. So I will give this back now to Corinne and Dr. Pasik, and thank you. I'll be here to answer your questions at the end.
Hey, Dr. Grube, thank you so much for that. A lot of great information. So I'm going to turn this over now to Dr. Deborah Pasik, who's going to talk about how this operates specifically in New Jersey. I just want to remind folks, if you've got questions, just look to the bottom of your screen to the Q&A box, type in your question. I'm going to take a look at them right after Dr. Pasik is done speaking, and we'll get to as many of them as we can. All right, Dr. Pasik, take it away.
Hello again. So now we have to get down to the specifics about practicing care of patients who are seeking medical aid and dying in New Jersey. Practically speaking, the majority of these patients, well, actually all of our patients, all of my patients have been new patients to me. I have become a prescriber because I felt that there was a need for it, and the patients that I see are not my patients. So there's an extra step involved in this sort of situation. Patients cannot make a cold call appointment to see me. When they do call, the first thing that I do is I request their records. And once I get their complete medical records, I can pretty much tell most of the time whether they are eligible or what I call pre-eligible. But if there's any doubt, I send the patient's treating physician a very brief questionnaire with 3 questions in it. And these questions are: 1, does this patient have a terminal illness? Yes or no checkboxes. 2, is this patient eligible for hospice? Yes or no checkboxes. And 3, is this patient able to make their own healthcare decisions? And one would think that the first 2 are a little redundant, but in fact, many physicians are not comfortable putting timeline prognoses in writing in a medical record. And so the second question kind of gets around that. And if the physician says, yes, the patient is eligible for hospice, that's good enough for me to think that this physician in fact feels that this patient has 6 months or less to live. So then that helps me feel comfortable in seeing a patient that I don't know, that I will meet for the first time in their first formal request. Next slide. So the first formal request is the first time that I'm actually seeing this patient. And before COVID, they were all office visits. And after COVID, they were all virtual visits. And shortly after starting with the virtual visits with these patients, I just became acutely aware of just how much better this was for them. The patients that I was seeing were coming from all over the state, many from South Jersey. And they were getting in the car, they were having to get dressed, get in the car, drive an hour, hour and a half, even 2 hours to come to see me. And as you can well imagine, a terminally ill patient going through this process, by the time they arrived in my office, they were so spent and exhausted that the first thing they would say when they would walk in was, I don't think I could come back again. This was just too much for me. Patients came in wheelchairs. Patients came in with assisted external ventilation, the ALS patients. I even had a patient come in a stretcher because she couldn't even sit up. So having now done the bulk of my work with the virtual visits, I don't see any turning back from that. It's just the perfect environment to conduct these visits. The patient doesn't have to go through the exhaustive stress of getting ready and getting in a car and driving. And also, very importantly, they can have their family around them as being part of this conversation, and we do encourage that. So it's just been very gratifying to be able to see patients in their own environment with their families and have these in-depth discussions. And I'm just hoping that, and very encouraged that I think at least in New Jersey, we will be able to continue these virtual visits. Next slide. So the purpose of the first visit is twofold. One is to establish eligibility. Obviously, the patient has to be an adult and a resident of New Jersey. Now, residency requirements are different for every state. So in New Jersey, we just need to see, there's no time frame that the patient needs to be a resident, but we do need to see some form of government-issued ID, such as a driver's license or a voter's registration card or a tax return. But patients, because we're in this tri-state area, and I do see a fair number of patients who are getting their care in surrounding states, particularly at Sloan Kettering, we have to be really careful to make sure that they are actually residents of the state, not just moving in with their children to establish residency. It has to be official. And in that situation, when they move in from New York to be with their children in New Jersey, I recommend that they actually sign a lease with their children, you know, paying a nominal amount of rent so that there is an official documentation of residence. The other thing I wanted to mention about eligibility is the ability to self-administer. The ability to self-administer really refers to the ability of the patient to get the medications into their digestive tract. And this can be through their mouth, it can be through a PEG tube, an NG tube, or even in some cases a rectal catheter when their bowels are totally obstructive and or not absorbing. But the common denominator is that the patient has to be able to deliver the medication to his or her lips via a cup or a straw if a caregiver wants to hold the cup. And when it comes to administering these medications through other means, the syringe can be prepared and filled by a caregiver, but the patient needs to have the strength and the wherewithal to be able to push the plunger on that syringe. Next slide. So the second important part of the first evaluation is to discuss and document the rules and the suggestions. So one documentation that's very important to have seems a little obvious, but patients need to be informed and understand that once they take these medications, they will die. They will more than likely die. And they really need to have that, sink in. Of course, we review all end-of-life choices and make the appropriate referrals. And the one that I really dwell on is enrollment in hospice. Many of these patients, even though they have a terminal diagnosis, are not in hospice, and they have a prejudice against it. They don't want anybody involved. They don't want hospice to know what they're doing. But I do encourage them to enroll in hospice. And what usually gets them over the hump of agreeing is when I tell them that when they die, if they're enrolled in hospice, then the family doesn't have to call 911. Otherwise, if they die at home without being under the care of hospice, the family does need to call emergency services, and that adds a bit of drama to the patient's death. We of course encourage notification and or participation of as many family members as possible, even if family members are not supportive of the patient's decision. Studies have shown that notifying these family members of their decision will be easier and less traumatic on the family knowing ahead of time than finding out afterwards. We go over the post form. If they don't already have one, I do complete one for them. Next slide. Another important point is that these drugs cannot be taken in any public spaces. Some patients have fantasies about having a beautiful setting at a beach or in a park, and that's not possible. It needs to be in a private setting and certainly not in a hospital or hospital facility. Again, we have to confirm that the request is by the patient and that there is no coercion. If there's any hint of that, pushy family members or whatever, then I speak to the patient in private and make sure that they are in fact requesting this of their own volition. Another very important point to document is that you inform the patient that they have the opportunity to rescind this request at any time. Certainly older patients, more old-fashioned patients that do what the doctor tells them, quote unquote, if they get a prescription, then they may feel obligated to take it. And we have to stress that the prescription can be taken home and it doesn't have to be used. It's totally up to them. Another thing I do is I offer supportive services. I know that Dr. Grube, has made many house calls, and that's not really possible in New Jersey unless it's in my neighborhood. And I do feel it's very important that there be a supportive person other than the family alongside the patient. And to that end, I and two other people have started, we're going to be launching an organization in New Jersey specifically to address these issues. And we've been gathering volunteers to actually be this supportive person. The types of volunteers that we have are social workers and nurses and end-of-life doulas. And a shout out to the end-of-life doulas specifically, because not only can they be present at the end, but they can be present at any time, sort of like the navigator that Dr. Grube was talking about, to take the patient through the whole process. And what they do, what all these supportive people do at the end, is that they relieve the family of the stress of having to follow the instructions for the medication, for mixing the medication, for the timing, for positioning. And they also relieve the family of any kind of conflicting emotional burdens that they may be feeling about active participation in their loved one's death. Next slide. So after the first visit, I usually schedule the consulting physician visit for my patients. I do have a list of consulting physicians that are available to me and to the patients. And as Dr. Grube said, the role of the consulting physician is to review the records, confirm eligibility, and submit a written report that then gets sent back to me that I need to have in the chart before I see the patient for their third visit or their second visit with me. Next slide. Just a note about decision-making capacity. Dr. Grube did touch on this. The main point I want to make is that mental illness or a mental abnormality is not necessarily a contraindication for medical aid in dying. It has to be determined that this mental condition is interfering with decision-making capacity in order to exclude the patient. Now, practically speaking, with the 32 patients that I have evaluated so far, I have made a determination, only one of them, that they did not mentally qualify and have not felt the need to refer anybody else for a mental health evaluation. Patients are extremely informed, extremely educated, and extremely clear in their wishes. Next slide. The written request that is required in addition to the 3 doctor visits is called in New Jersey the request for medication to end my life in a humane and dignified manner. And this is a form that is available on the New Jersey Hospital Association website. I believe, Corinne, that Compassionate Choices also has it for New Jersey. I'm not sure. But you,
yeah, there's a link on our website.
Okay. But you can get it online at the New Jersey Hospital Association website, and I actually provide this form to the patient in their first visit packet that they have to that they get before seeing me. The rule in New Jersey is that this written request needs to be in the patient's chart at least 48 hours before the prescriptions can actually be submitted to the pharmacy. So I encourage patients to get them into the chart before their next visit. Dr. Grube did touch on the requirements for the witnesses. Next slide. So the second visit, it's a formality in some ways, but it still is important for several reasons. One is that I'm reviewing the consulting physician's assessment and the mental health assessment if applicable. But the main thing is that I have to confirm 2 things. I have to confirm the eligibility because things can change dramatically in 15 days, really dramatically. A patient can go from being mentally competent to be mentally incompetent. A patient can go from being able to self-administer to not being able to self-administer. And so these assessments need to be done again at this second visit. Again, we stress the opportunity to rescind, and then I go over the details of the whole process, which we'll go over in the next slide. So I go over detailed instructions with the patient. First of all, how to pick up the medication. They need to call the pharmacist with a 24-hour notice because number one, the pharmacist needs payment in advance. It costs about $700 for this D-DMA prescription. And of course, the pharmacist needs to compound the medication as well. So the pharmacist does need a little bit of notice. The patient can designate a surrogate to actually pick up the medication. They just need to tell the pharmacist who that person is going to be. And this is an important point because there are very few pharmacies in New Jersey that are willing and or able to provide this service. And so again, that patient from South Jersey may have to drive all the way up here to a pharmacy to pick up their medication. So designating a surrogate is a very viable option. And I also want to make the point that the prescriptions need to be delivered directly to the pharmacy by me. I cannot give the prescription, the actual written prescriptions to the patient. Of course, they're instructed to maintain these medications in a safe and secure location. And if they are not used, then they need to designate a specific person that will lawfully dispose of these medications. And this appears on the back of the written request. And that is done by dropping the medications off at a police station that has an anonymous drug drop box. So we also go over the details of how to prepare and ingest the medication. And I also provide a written instruction sheet with these details, along with the prescription, that the pharmacist then also goes over this with the patient when they meet with them or when they meet with the surrogate. We also talk about what to expect. A lot of patients are afraid that they're going to be awake when their heart stops, and I reassure them that no, they're going to fall asleep very quickly, usually within minutes, and that their heart will stop within an hour or several hours afterwards, but that they won't be cognizant of what is going on. They will be sleeping peacefully through it. I also ask them to notify me more or less of the date of their intent, just so that I'm around in case they need to contact me, or their caregiver needs to contact me, or if I'm not around, that I have coverage so that somebody is available on the phone to answer questions. Next slide. So I just wanted to end with, the experience in the last year and change in New Jersey, and all the barriers that we as physicians and patients have experienced. And all of these barriers are really access to care. Access to prescribers. There's no list of physicians available to patients. It's all word of mouth. Access to pharmacies, I touched on. Access to hospices that are friendly and supportive towards medical aid in dying. We do have some hospices that are actually quite hostile. A lot of the religious-based hospices do not even want patients to be part of their family, and which is actually, I believe that's against the law, but a patient can't be turned away because of their beliefs. But this actually has happened, and we're on it. We're on the New Jersey Hospice Association, telling them about any incidents like this that have happened, and slowly we're kind of making headway in getting hospices on board by speaking, speaking engagements, and these have actually worked out quite well in the last few months, in the sense that I found that the last 5-6 patients that have been referred to me have been referred to me directly from hospice providers, which is really excellent. I did talk about access to volunteers, which we're working on, and also just general support for patients and physicians. It's disappointing that the Medical Society of New Jersey has an opposition stance towards medical aid in dying. Hopefully they will change their minds soon. There's also the issue of institutional support or opposition. New Jersey, as we all know, many of our institutions have been bought up by larger and larger institutions, and so we have these enormous hospital systems that kind of reign over all of the smaller hospitals and employ many physicians, and physicians are really have to abide by what their employers are supporting or not supporting. So fortunately, my hospital system is supportive, and so I've had an easy time of it. But again, I think with more education and exposure, hopefully things will come around. So lastly, I just wanted to offer my services to any of you that may want to talk, that may want specific instruction, any help. I can walk you through it step by step. I can give you my notes. I can give you my note templates as far as documentation. Anything you need, my name and email and office number are there, and just feel free to reach out, and I am happy to help. Thank you.
Thank you so much, Dr. Pasik. My fault, we didn't leave ourselves a lot of time for questions, but I'm gonna take a look here at the box and see what I can see. There we go. What can we see? Okay. We've got a question from Dr. Grube, I want you back. If you can come back on camera, great. So we've got a question about, do we, I guess Compassionate Choices, provide training to become a prescribing or a consultation physician if I'm in the field of anesthesia? I have an interest in the end of life, but no, not fellowship trained. Who wants to take a stab at that first? Dr. Grube, Dr. Pasik?
Sure, I'll answer that. We do have many different training opportunities through Compassionate Choices. We have, and some of those I listed, but we have YouTube videos, and we have educational programs, and we have the doc-to-doc line, so that if any doctor in any authorized state has questions about a patient, they can call the doc-to-doc line for Compassionate Choices and get their questions answered by a doctor who is practiced medical aid in dying. In New Jersey, as in Oregon, any licensed allopathic or osteopathic physician is authorized to provide this service. Now, of course, I think with anesthesia, your specific example, we have a vast knowledge about providing medications that are used in medical aid in dying. Perhaps not so much in evaluating what the prognoses, et cetera. So maybe as a consulting physician, but there is no national certification for medical aid in dying. Any licensed allopathic or osteopathic physician in New Jersey can provide the service.
Anything to add, Dr. Pasik?
The only thing that I have to add is, apart from the great resources that Compassionate Choices have, I'll just reiterate what I said a few moments ago, that I'm available to anybody that wants coaching.
Great. All right, we've got 3 more questions. Just a reminder, if there are folks on the line who would still like to ask a question, you can type it into the Q&A box at the bottom of your screen, and we will have time to answer them. Are death doulas employed by your organization? Is this something that the organization would consider to assist with medical aid in dying? I'm going to throw that to you, Dr. Grube.
Yes, we do not employ any death doulas. I know about death doulas. Death doulas are much more prevalent in the East Coast than in the West Coast, and hospices now are employing them. So generally in this arena, the death doula is more associated with the hospice, as we don't actually, Compassionate Choices doesn't actually have, other than me, any clinicians.
I would add that we have an end-of-life consultation program that folks can call our 1-866 number, our toll-free number, and talk to an end-of-life counselor who can talk about options. Dr. Pasik, though, you might have something to add about your organization and working with doulas, no?
So my organization is just getting off the ground at the moment, but we are fortunate to have several end-of-life doulas that have generously volunteered their time to help patients in the medical aid and dying process. And you know, I have just practical experience with just one patient that was just mind-blowingly amazing. And since then, I have recommended these ladies to other patients, and hopefully they will participate.
Yeah, we featured a doula on the last webinar that we did for patients in New Jersey, and that doula was fantastic. So hopefully we'll see more of that involvement. Next question comes from Dr. Thomas Ziering. Hope I'm pronouncing that right. He'd like to confirm who would be the second person to certify for medical aid in dying other than the doctor. And I think I can answer that question, but I'm going to throw it to Dr. Pasik.
Well, I'm assuming that you're talking about the consulting physician. So the consulting physician can be any physician. Any physician is qualified to be the consulting physician. It's just a matter of having two independent physicians confirming eligibility for this process. So it doesn't. I know a lot of people have think that perhaps the consulting physician has to be in the field of the disease of the patient, but that's not a requirement. It's if you're more comfortable, for example, you know, having a neurologist consult on an ALS patient, or an oncologist consult on a cancer patient. That depends on your comfort level. But by law, it can be any physician can be the second opinion.
Dr. Grube, anything to add to that?
No, I think you said it very clearly.
Okay. Next question is from Wendy Dunkel, who says, with an ALS patient, you are not able to determine if they have 6 months to live. So how does one suffering from ALS request medical aid in dying? Dr. Grube, why don't you go first?
Sure. Well, ALS, that's a very good question, and it's a hard question. But ALS has many different paths. There are people who will die of their ALS in weeks, and people who will die of their ALS in years. So generally, it's the slope that might help us understand, or comorbidities, etc. So, but I would say, in my experience, that physicians who have experienced treating this horrible disease will err on the side of the patient who is suffering to determine the prognosis. But you can't just say in ALS that we don't have any idea how long they're going to live, because I can think of one ALS patient who I saw that by the time they got into the neurologist 2 weeks later, they were almost on the vent. So it's different for many different patients.
Dr. Pasik, anything to add?
So I've actually seen 5 ALS patients so far, and this was the question that I asked as well. How do I determine prognosis? And I went to the hospice requirements for ALS, and they're very clear. There has to be a certain rate of deterioration. There has to be a loss of certain functions. And certainly a patient that is bordering or just beginning to have respiratory difficulties and require external ventilation, sure, of course, their prognosis can be much longer if they agree to ultimately go on a vent, but that patient doesn't want that. So you can prolong the prognosis of an ALS patient artificially, but the patients seeking medical aid and dying are those that do not want to have those artificial means of sustaining life. So I've been going by the hospice criteria, which are really quite clear.
And I think that's a great answer. And I think that it's so true in all cases. If your patient does not really meet criteria to be eligible for hospice, whether or not they enter into hospice, they're not eligible for medical aid in dying.
Thank you both. The last question that we have, and just for those of you who are still on, and it looks like everyone that joined is still on the webinar, if you have any last minute questions, type them in the Q&A box. But the last question is for Dr. Grube and I. Does Compassion and Choices reach out to medical schools to educate new physicians? Or maybe all of us can address that. Dr. Grube, what's your answer?
Yeah, I think I've been to about 15 medical schools providing education. I might refer you to Diane Ream's new book, When My Time Comes. And there's a chapter in there of me giving a lecture to medical students at Georgetown in DC. So yes, we do, and we will continue to, and there are more and more requests all the time.
Dr. Pasik, anything to add?
I totally agree. I think that this education should start very early. I mean, things have really changed since I went to medical school. I mean, medical school now, having a daughter having gone through it, and a niece who's now in medical school, medical students are much more sophisticated than we used to be, I think, as far as getting real world humanitarian education. And they're very much aware of the issues. And so I think educating them, giving them the tools to continue on this education is just really important.
Great. Well, I'm going to share my screen one more time before we end up for the evening, because I would like to put these numbers back up of Dr. Pasik and our 1-800 number. And then also, you know what? I'm actually thinking that's, yeah. Dr. Grube, I wonder if that's a 1866 number. Is that a typo? I think it's 1866.
No, I think that's correct. That is not correct.
A little nervous for a second. So just those are the numbers where you can reach us. You can always reach out to me. A word about the training in medical schools. If anyone on the phone or on this webinar would like to have us come out and do, well, not in person, but if you'd like to bring us virtually to any institution or any group to do a training, we're happy to do that. And in the future, travel in person again. I just want to end by saying that Compassion and Choices is funded almost exclusively by individual donors. With sufficient resources, we can realize end-of-life choices in every state, and every donation of any amount makes a difference. If you got something valuable out of this webinar and you'd like to see this work continue, please consider making a donation of any amount today. You can go to our website, compassionandchoices.org/donate, or if you go to our website, there will be plenty of opportunities for you to click a donate button, I promise you. So consider doing that if you found this presentation valuable. I want to thank you all for joining this evening. I don't know why that went to the beginning, but thank you so much for joining. And, please contact us if you have questions in the future. Thank you, Dr. Pasik. Thank you, Dr. Grube. And to our technical support, Joe Stone, thank you so much for making this webinar go smoothly. Have a good night, everyone.